Here we are gathered together for a very nice session of Haryana Ophthalmological Society, and I would like the chairpersons to take their seats on the dais. Dr. Dhul sir, Dr. Markande sir, Dr. Praveen Arora, Dr. Chauhan is still awaited, Dr. Manisha Rathi is awaited, and Dr. Sumit Khanduja. I'll ask the first speakers. First speaker would be Dr. Markande, sir, and he will be speaking on Axenfeld-Rieger syndrome, a case report, and we'll start the session now. हाँ जी सर तो है ही नहीं मेरे को तो लग रहा है हम भी नीचे ही बैठ जाएं हम सारे ही नीचे बैठ जाएं तो थोड़ा सा भीड़ लगे रुक जाओ
Respected chairpersons, dignitaries of the dais, and of course regards to the chairs which were expected to have more dignitaries here. I am presenting a case of Axenfeld-Rieger syndrome which came to my OPD. From 3 years she has been following me up. In fact, this is the picture of the Axenfeld-Rieger syndrome, what it can all involve. In eye, of course, it is posterior amylotoxin, peripheral anterior synechia, correctopia, iris hypoplasia, pseudopolychoria, but it can also be associated with cerebral hypoplasia, sensorineural hearing loss, craniofacial dysmorphism, dental malformations, congenital heart defects, and of course the redundant periumbilical skin. This is a case of Sonia, 20 years old. She is an athlete from Rohtak itself. She came to me with headache only. And of course, she was having pain around both the eyes since early childhood, which was insidious, dull aching, progressive, more in early morning, relieved on taking medications, and now often on severe headache. She was unable to speak and listen also. There is no other history of trauma, nausea, fever, any other ocular surgeries, blood and vascular disorders, palpitation, breathlessness, hypertension, diabetes, or tuberculosis. She had visited another ophthalmologist where she was diagnosed to have anterior segment dysgenesis and was prescribed the drops I have mentioned, latanoprost, brinzolamide, and timolol. Personal history: diet is mixed, appetite is normal, sleep is adequate. There is a family history, of course, of the father and the mother consanguineous marriage, history of similar complaints in the family. General physical examination was essentially all right. She is 170 centimeters in height, very well built, a smart girl in fact, but is deaf and dumb and is having eye problems. Her CNS, of course, was normal. Ocular examination, I will only mention the positive findings. The positive findings were, of course, the gonioscopy, the detached Schwab's line in all the 4 quadrants. Iris atrophy was present in both the eyes. Correctopia, reactive to light. Correctopia with pseudopolychoria was there in the left eye. The left eye was more affected than the right eye. The CD ratio, of course, was also increased. And then foveal reflex was normal. General background and blood vessels, they were also normal, but IOP was 26.4 and 24.5. This is the picture of the girl where you can clearly see the iris atrophy, the correctopia, and of course the polychoria. This is the UBM picture of the female. Of course, you can see the thinned out iris and the ciliary body and high insertion of the iris. This is the anterior OCT of the same patient. And these are the fundus pictures. This is the ultrasound, and of course on OCT the RNFL was reduced in both the eyes. Posterior amylotoxin is a clinical and histological term referring to displacement of Schwab's line anterior to the limbus in the cornea. Rieger described patients with congenital iris abnormalities including iris hypoplasia, correctopia, and polychoria, now referred to as Rieger's anomaly. Rieger anomaly associated with systemic findings such as dental, facial bone defects including maxillary hypoplasia, umbilical abnormalities, or pituitary involvement is known as Rieger syndrome. The combination of Axenfeld anomaly and Rieger syndrome is known collectively as Axenfeld-Rieger syndrome. The genetics, of course, are very important. 3 genes have been identified: type 1, type 2, and type 3. The general role of course, it is the transcription factors binding to DNA, control the activity of other genes active in developing eyes and other body parts before birth. They are important for embryonic development, particularly in forming structures in the anterior segment of the eye. The medical management, of course, is brinzolamide. 1% I'm keeping her. She is nice. She is maintaining well. Surgical has not been planned as yet. Axenfeld-Rieger syndrome is a rare autosomal dominant neurocrystopathy that presents with a variety of classical ocular and systemic findings. Of course, the anterior segment dysgenesis is the main. The most common ocular features of ARS are posterior embryotoxin, iris hypoplasia, while some patients may manifest as corneal opacity and edema. The main pathogenesis of ARS is abnormal migration and differentiation of neural crest cells during the embryonic period, leading to multiple phenotypes. Axenfeld characterized by posterior embryotoxin and it stands adherent to the anteriorly displaced Schwab's line. Epidemiology and pathophysiology, I am just mentioned. The clinical characteristics, of course, are very important. As I mentioned, correctopia, polychoria, ectropion uvea, posterior embryotoxin, and increased intraocular pressure. The most common recognized clinical manifestations are, of course, iris correctopia and atrophy and posterior embryotoxin. Occasionally, patients have megalocornea and microcornea. The iris stands adherent to the Schwab's line, which was present in this case also in the right eye. The facial abnormalities, of course, are there. The dental abnormalities are there, but in my case, I never found any facial abnormalities and dental abnormalities. And of course, the case of empty-sella syndrome and arachnoid cyst have also been reported. Growth hormone deficiency and short stature have also been described, but this patient was healthily built. Glaucoma is seen in approximately 50% of such cases with ARS. Developmental arrest of the neural crest cells with a retention in the anterior chamber angle during gestation results in incomplete development of the trabecular meshwork. So the management includes, right now my patient is on only medical management. The surgical management, of course, has not been planned in this case, but you can always have surgical outcomes if the pressures are not controlled. Thank you very much.
Thank you, sir, for a very interesting case, and we'll have a discussion at the end. I'll now request Dr. Manisha Rathi, because she has to go for another presentation to make a talk on phacomorphic glaucoma series, a patient profile.
Thank you so much. It is a real honor to be here with my respected teachers, colleagues, and all the people I really like in the world in ophthalmology. Thank you so much for having me here. And I had given this session, so I've tried to include all the names possible. Phacomorphic glaucoma. While we are talking about the cutting edge, vertical, Dr. Nalini, vertical. While we are talking about the cutting edge of technology, and people are discussing how to go from point 8 to point 6, we still have a large group of patients, largely forgotten, who still present so late to us with vision-threatening complications. So this is a series of our cases of phacomorphic glaucoma. First of all, why are we talking about this? Let's take a look at the magnitude of the problem. This is more in patients who have pseudophakia and good vision the other eye. Although we need both eyes, but they cannot sometimes afford to come early for the other eye treatment. Incidence of lens-induced glaucoma in developing countries is almost 2.5% with a female preponderance. In our experience, this is a series of 24 patients, all above 50 years of age with senile cataract, who presented to us with phacomorphic glaucoma. This was done in the last 1.5 years, so a large number of patients. A thorough comprehensive history taking, examination, and workup was done of the patient. All data, such as whether male or female, rural or urban, education level, and socioeconomic level, distance from the hospital, and level of intraocular pressure at the time of admission were taken into consideration. So no surprises here. As the global data indicates, female preponderance, in our cases, a staggering 62.5% of the patients were females. Residents, and again we are a free government college and we cater to a largely rural population, so they were mainly rural patients. Education status, the large majority of them, 83%, were illiterate. Occupation, most of them were not employed. Socioeconomic status, again, we took this from the charts that we have for regulating how much of the income is considered in which socioeconomic level. So less than 5,000 rupees per month was 66% of the patients. And the causes of delayed presentations among the men, it was mostly good vision in the other eye because of pseudophakia, and in women it was mostly failure to communicate to the family members. They do not want to be a burden or ask somebody to take them to the hospital because they were not mobile on their own. This was inconsequential, the marital status. So in all the patients, among all the reasons studied for delayed presentation, a very delayed presentation, vision threatening delay, was the rural and urban areas, lack of awareness, followed by family issues and nobody to take them to the hospital. Duration at the presentation, less than 7 days was only 2 people. 7 to 14 days was the majority of the candidates, that is 33.3%. And really shockingly, more than 6 months, 3 patients came who obviously did not present. 2 of them had PR inaccurate, 1 of them had PL negative vision. Presenting intraocular pressure, more than 40 in more than half of the patients. We were told, if the pressure is high for 5 days at this level, your optic nerve will be knocked out. But luckily, it doesn't happen to our patients because the prolonged intraocular pressure somehow either saves them, or we need to do studies on what level of intraocular pressure damages our eyes. Presenting visual acuity, as you can understand, the 3 patients who were more than 6 months old had very poor prognosis and very poor visual acuity. Now you see this in the other eye. We are getting this even now. This study is continuing now. I have 75 patients enrolled in this study, and 12 out of them, that is 50%, had pseudophakia in the other eye. So they had good vision in the other eye, and they said, it's all right, I can wait for some more time. Factors contributing. These are global factors which contribute to a very late presentation. Misdiagnosed. Sometimes they have slips from dispensaries or hospitals in which they have not been diagnosed correctly. They've been told, take some medication, you have pain in your eye, and go later to the hospital. So misdiagnosis or underdiagnosis. This is from studies in other countries also. Lack of awareness. They do know that they have something that needs to be taken care of, but the magnitude of that problem or the potential risk they are not aware of. Then barriers, economic, social, and probably family issues. Fear of surgery, misconception about eye surgery. Delay in seeking treatment for cataracts is a common precursor. So this was a large study done in 452 adult glaucomatous patients for late presentation. Late presentation was considered as a CD ratio of more than 0.8 and a mean deviation in the visual fields of more than, depression of more than 14 decibel in either of the eyes at first presentations. They were divided into various groups and studied statistically. So as you can see, more age, 60 years or more, increasing intraocular pressure. In this study, it was 30 or more. Knowledge of glaucoma, which was poor. Residing far away, it was 53 kilometers in that study, residing far away, and we have found similar results from the hospital. And absence of regular eye checks was significantly associated with the late presentation. So what should we do? We cannot let this go, because if one eye is lost, we lose binocularity, and also if we can do something to prevent it, it's our duty to do that. Education, awareness, improved access to care, outreach programs, patient counseling and support. So what is the conclusion? This is more prevalent among the illiterate, among women, among people who are not aware, who are living far away from the hospital, who have higher pressures, and there's an increased need for screening programs, outreach programs. Because what is the ultimate goal? To prevent visual disability, preventable cause of blindness, and blindness. So this is us in ICCUS camp. We screened 884 patients and brought the patients there. This was in 2024 and 2025 in March, just before World Glaucoma Week. We have screened 664 patients, and 10 of those patients have got operated by us. Regularly, 2 patients to 4 patients are coming each week. So this is what we need to do. And this is our OPD on any given day. We are lucky to be looking at so many people. Thank you so much for your kind attention.
Thank you so much, ma'am, for a very pertinent study. And we have found that literally these people, they have nowhere else to go, and they come to us in large numbers. I would ask Sir, Dr. Chansing sir, to make a comment on that, please.
I'm worried that in Rohtak and the catchment area, where so many ophthalmologists are there, and being a RIO, means that is the pathetic situation that so many people are unaware about this problem. That's really
So we are going to the
alarming.
doorstep. We are going to the doorstep to provide service, and
I'll
but
say
now they
it's
are coming.
really alarming.
Thank you.
Thank you.
It was much more even. Dr. Johan will bear me out when we were operating ICC in 90s. I think we every day had 4 to 5 patients who had phakomorphic glaucoma, and of course with PR inaccurate also. That time we were bold enough to operate upon them. Today we are timid to operate because of the medical legal cases. But then we operated upon them, and to my surprise and his surprise, people used to have 612, 6/9 VN despite having phakomorphic glaucoma for 3-4 days. So if they come within a period of 1 week, the experience has been that they can have at least a reasonable VN, and as you rightly said, binocularity.
I had another table of the outcomes of 1 week was excellent, 6/6
Yes,
to 6/9.
true.
And this 3 months to 6 months also, surprisingly, there must be massive field effects.
Yes.
But they did have 618
Central
vision
VN, yes, you are
following
right.
that also.
And last thing, what procedure do you follow in such phakomorphic glaucoma
Sir,
cases?
W trabeculectomy with glaucoma. For all patients above 40, I have a series of 90 patients. We do a W-shaped incision for so that you can resect 2 by 1 millimeters of the sclera. I sent it to histopathology also, and we have had very good results.
It's a very good results. I have seen the patients myself, and literally they're very well controlled over a long period of time. I think you have I think last was 10 years, 14 years of
20 years.
follow.
20
follow.
years.
I don't know. Okay, so we'll have the next speaker, Dr. Dipender.
Just a minute,
and-
sir. Dr. Sachdeva,
Yeah.
I would like to comment. I saw a patient. She was mother of a fellow colleague, eye surgeon. He went to his village and found that his mother was having pain. He brought him to Bhiwani. And she was found to have phakomorphic glaucoma. She had been having pain for the last 11 days. Then I operated her. And she got a vision of 6/36. And although we say that I did not do trabeculectomy, only the cataract extraction was done. And she had good vision. You can say 6/36 good vision. Cornea remained clear. And just wanted to tell you that vision can be so good even after 11 days of severe pain. Pressure, of course, was more than 40. Thank you.
Hello. I want to make a comment. Actually, sometimes what happens if the phakomorphic glaucoma remains for more than a week, then sometimes the synechia formation occurs, and sometimes it becomes recalcitrant glaucoma. So the pressure is not coming down even with the mannitol. And before surgery, if the pressure is not coming down, you can actually aspirate the vitreous. Little amount of vitreous aspiration will bring down the IOP, and then you can proceed with phacoemulsification, and you can start systemic steroid with good results.
I take your comment, sir, but actually the retina people sitting beside me, they are not agreeing to that because they don't want you to aspirate the vitreous. Although I have seen people doing what they do is they just put in the needle and then let it remain there so that whatever extra is there, it will come out itself. Don't pull, because pulling can cause traction on the retina. So dry vitrectomy, yeah, that's what they make a port, make a dry vitrectomy.
That deepens the anterior chamber
Deepen it.
and makes.
So Dr. Dipender would be speaking on 10 cases where multimodal imaging made an impact on the vision.
Yeah, I'll try to present 10. May not be 10 because I didn't know it will be just 6 minutes. So bear with me, but I'll stop when my time is over. And thank you, and it's always pleasure and honor to be with our dear HOS colleagues, seniors, teachers. So this first case, he was around 70-year male. He came with complaints of floaters, and he was examined by one of our colleagues and almost declared as normal. And when we saw that there is a peripheral patch, this paint-like patch in extreme periphery, and we just clicked fundus picture, and we tried to see the magnified view, and if all of you can make out, there is an occlusive arteritis going on. And with just a simple good color fundus picture, we could make out that this is nothing but viral retinitis starting in periphery, and you can see with intravenous antiviral and then followed by oral maintenance of dose of oral antivirals. I think the whole retinitis resolved nicely. There was a history of herpetic encephalitis 6 months back. So So just with a very good quality fundus picture, we could make out that this is a viral retinitis. Now another lady, she had a history of carcinoma breast 10 years back, very well treated, in remission. She came with sudden drop in vision, vitreous hemorrhage, some infiltration and hazy media like this. And we said, okay, fine, we'll start some steroids because there was cells in vitreous and there was vitritis. And we started doing workup for primary metastasis anywhere else in the body. And this is how you can see again imaging helping us see that there is some subretinal deposits, choroidal elevation, and what they call as lumpy bumpy choroid. You can see this speed breaker like appearance in choroid. But most striking for her was when we went for ICG. Now indocyanine green angiography is beautiful when you have to rule out metastasis, because most metastasis will be jet black, and it makes our differentiation from melanoma and other primary ocular tumors very simple. So this is again a very useful use of ICG, and we have had now a series of patients where we had a doubt. We went for ICG, jet black lesion. It tells us that this is nothing but metastasis. And finally, it was confirmed that she is having a recurrence and metastasis. Now, another patient having some floaters and not much change in vision. You can see 6/6 vision in both eyes. But when we went for angiography, we could make out in nasal quadrant there was some stippled hyperfluorescence and this leopard skin-like appearance on FFA. But we still, and at that point we did OCT also over that nasal area, and you can see that there is some splitting between Brooks membrane and RP happening. But we still thought that because viral retinitis is something which can progress very fast, so our first DD was still viral retinitis. We advised antiviral. He didn't turn up. He came back after 6 weeks. Now vision has dropped, and same thing is now involving macula. But now I think picture is quite clear, and you can see this RP getting separated from Brooks membrane and subretinal deposit, and lot of vitreous cells, and they are very well defined, reasonably large cells. So of course we still said let's give him a trial of antiviral and steroids and see whether he will improve, but he didn't. And when we finally went for diagnostic vitrectomy, it came out to be primary intraocular lymphoma. And when we go back in literature and see the OCT findings which we were observing at macula was very classical of primary intraocular lymphoma, and he responded very well for intravitreal methotrexate. This patient, again, he was having some mild uveitis. All the serological investigations were normal. He was having occasional flare-ups which was very well controlled by topical and rarely with oral steroids. And then when we took a very detailed history, he had some history of mouth ulcers and genital ulcers. He came out to be HLA-B51 positive. But you do angiogram for these patients, the picture is much more striking than what color picture shows you. There is a diffuse leak around all the vessels, cystoid macular edema. So he fits very well into Behçet-related retinal vasculitis, which keeps coming and going like this. So again, now he's maintained at 6/6 with 8 years follow-up. So again, imaging helped us. Another lady who came with headache and this kind of sudden blurring in both eyes, some disc edema, and when you see a picture like this, you will always wonder whether it is posterior scleritis or is it VKH or is it APMPP. And angiography is showing hot disc leakage at optic nerve head and pinpoint leaks also at multiple points. But the moment you do ICG, I think ICG again is a very striking, has a very striking imaging appearance of this disease called VKH. What you see is uniformly distributed these black areas. This is nothing but hyposenescence because of inflammation of choroidal stroma, which is quite uniform and diffuse, and it's strikingly bilateral. Sometimes disease looks very asymmetrical, but on ICG it is quite symmetrical. So diagnosis was very clear once, and we gave her steroids followed by immunosuppressives, again maintained very well. Now sometimes you go for fundus and FFA and you forget your basic OCT scans. Now look at this patient, young lady, which she came with sudden drop in vision, and what you can see here is this boat-shaped subhyaloid hemorrhage, and there is a ruptured retinal artery macroaneurysm which has led to this. Some hard exudates on this fundus picture, and angiography is showing relatively normal looking fovea and macula. But let's see what's happening at the fovea on OCT. There is significant traction there at fovea along with all these findings which I have highlighted. So this was not a candidate for laser or injection. This was a candidate for surgery. We operated, and you can see this. He recovered quite a good 6/6 vision. So it was only because of B-scan OCT we could make out that it is the traction which needs to be addressed rather than just retinal artery macroaneurysm. Again, this PDR patient, just to highlight that sometimes you see when he presented, he was having 6/6 vision, subhyaloid hemorrhage, and after follow-up, hemorrhage actually gets absorbed, but vision drops. And why it's dropping? Because there is a traction which is developing at fovea. So again, B-scan is very important test for even when you you see macula which looks like very clear, not much of hard exudates or macular edema. Sometimes you can see traction in these kind of cases also. I think this one again was a patient complaining of sudden blurring when he was on traveling on a bike, and he came with this kind of lesion, choroidal lesion, and we thought whether it is tuberculoma or choroiditis. But when we did angiogram, we realized you can see the serial angiograms showing diffuse leak over the lesion, and you do OCT scan over this lesion, you can see this choroidal elevation, lot of inflammatory cells, full thickness retinal opacification, but no necrosis. So this tells you that it's not viral retinitis, it's probably a choroidal granuloma, and he responded very nicely to just oral steroids, and you can see this lesion regressing nicely. Again, a choroidal granuloma, and I think this was a patient where we were suspecting a CNVM which was not detected on FFA ICG, but OCT angiography showed it very well. So to conclude, I think multimodal retinal imaging can make huge impact in variety of clinical situations which we see in our clinic, and I would re-emphasize that it is still underutilized. Many of us have these imaging tools, but we are using it less than what we should. Thank you.
Thank you so much, Dr. Dipender, for a very interesting case series. And just two comments, one from Dr. Sumit Khanduja and one from Dr. Manisha Nada.
Sir, thank you for a very intellectually stimulating presentation. I think the point to learn from sir's cases is not to discard the role of old fluorescein angiography, because with the advent of OCT, most of us have shifted to a simple fundus photograph and an OCT. We try to take a scan through the lesion, while forgetting the fact that in angiography, fluorescein or ICG helps us understand the dynamics of the lesion. So I think that is an important message from sir's presentation, not to discard the role of angiography, sir. Thank you.
And
one question, Devendra, I want to learn from the retina people that any difference or any with Octa versus this ICG, which are one is non-invasive and other is invasive.
I think
Can Octa help us in all this?
this is a very commonly asked question, that which imaging is superior to other imaging. So they always complement each other, and then there are situations where ICG will beat Octa, but then there are a lot of clinical conditions where Octa has definite advantage of being non-invasive. You can repeat it almost every week, and you can do for all set of patients, including pregnant females, where you will hesitate to inject a dye. And it depends on pathology what kind of imaging you will use.
Especially in your cases where you saw the metastasis.
Yeah.
So in those cases,
ICG.
Octa will not be able to see much. Octa has a limitation of depth. It cannot go beyond a certain level of choroid. So if lesion is too elevated, it fails to show any useful information.
Thank you. And one comment from Dr. Manisha Nada, if you want to make a comment.
Thank you so much. I congratulate Dr. Dipender for his wonderful presentation. He is always ready with his best of the best cases we had seen at Kasoli also. I think we are also doing a pilot study on some cases from onco, and we see that the metastasis that we don't have the facility of ICG, but still on screening examination we are seeing that metastatic cases are different from what we see in other kind of melanomas or oncocytomas. So that study is being done. So I think next time I'm going to present that. So thank you so much. Yours was
Thank
very
you.
nice.
Thank you.
Thank you so much, ma'am. And sir, Dr. Indramohan has to go, so can he present? So Dr. Indramohan Rastogi, he'll be presenting on uveitis cataract, how to handle.
Good evening, all. So, cataract is most common complication in chronic uveitis, and the sequelae to chronic inflammation and chronic or topical steroid use. Incidence is around more than 50%, and it's the most common indication for surgery in such cases. So, the type of the cataract is posterior subcapsular cataract, and poor outcome is because of inflammatory sequelae, structural abnormalities, and high rates of co-pathologies existing along with. So, improved outcome has there in the recent time because of the proper patient selection and the biocompatible IOLs, improved surgical techniques, improved surgical capabilities, improved control of inflammation, and post-operative management of the complications. So, outcome also depends on the patient age, risk of amblyopia, etiology, along with the clinical course of the disease and the pre-existing ocular complication, and of course, the inflammation which is existing. In these cases, what are the indications? One is phacoantigenic uveitis, which is present along with, which is an absolute indication for this surgery, and visually significant cataract, which is there with the, of course, controlled inflammation, and where we want to assess the fundus. So, there also we do the surgery, and of course, where the cases which require pars plana vitrectomy. We have to put our attention to all these pre-existing conditions before we take up the case, especially from the cornea involvement up to the vitreous. So, in these cases, we have to always ensure a two-step surgery, two-step management for the cataract surgery. Step 1, we have to control the inflammation, and step 2 is we have to control the post-operative inflammation also. We have to always pay our attention to the blood aqueous barrier, because after the surgery there is a lot of inflammation, and because of fibrin formation, we have to pay our attention to that also. So, surgical procedure in these cases is a little bit complex, and it is a usually major challenge for the anterior segment surgeon, and intraoperative maneuvers with all these things which are there with the synechia, membranes, and all that. So, we have to use the iris retractor hooks. We should be very well versed with this, and sometimes because of the iris involvement there can be bleeding also, and vitreous haze and all that, they hamper the visualization. So, these cases, these things which are there in this iritis cases, constricted pupil, that is become a challenge. So, sometimes at the surgery we have to take decision of multiple sphincterotomies, bimanual stitchings with all these rings and hooks. So, we have to take decisions, and of course, the pupil size we have to increase up to 5 mm. We have to perform synecholysis, membranes are to be dealt with, and multiple sphincterotomy to be done. But at the same time, we have to take care of the anterior segment structure, so that the visual outcome is not hampered. Capsular axis has to be 5 to 6 mm, and if either it is a too small one, there will be problem peroperatively. If it is too large, unstable IOL. So, ultimate thing is that you have to minimize the iris trauma in such cases. Steroids are must, and use of dye can be taken up depending on the situation, but these cases are to be done under block only. Phaco-chop is the best, that is to be done in the chamber, bag only, and we can use modified IOLs, but parameters they are to be kept to the minimum at the time of the phaco. So, IOL material has to be acrylic or hydrogel. Implantation of the surface modified IOL, that will be taken up, or if uveitis is uncontrolled or less than 2 years of age, sometimes the IOL has to be deferred. So, wrong way in such cases that we should always avoid AC IOL. Warning is that try to keep the posterior capsule intact if possible, and place the bag in the IOL, so that if the haptics are placed in the sulcus, that will lead to the further uveitis, and the problem will be there. So, steroids are of much use into this, either oral or IV, or sometimes immunosuppressive medications are to be used, cyclosporins can be used, and infliximab, they depend on the situation, what kind of the, etiology is there, we can use that. Per-operative steroids are must, pre-operative steroids are must. We have to control the inflammation at least 2 to 3 months before the surgery. So in the immediate post-operative, we have to use frequent steroids. The frequency has to be much more, and during the night, steroid ointment has to be used. So successful outcome depends on the proper timing, proper control of inflammation, meticulous surgery, close monitoring, and advanced surgical technique. And immunosuppressive chemotherapy, if is advisable depending on the person profile, that can be taken up. So ultimately, dealing with this type of the cataract, fear, either forget everything and run, or face everything and rise. So if you face everything, you can have a successful outcome. Thank you very much.
Wonderful talk, sir, and very nicely given us a guidelines on how to manage the uveitic cataracts. And I would like to have a comment from Dr. Kapil, sir, for this. Any tips, sir, that you can for
Thank you.
Thank you, sir, for the nice presentation. I have a query, means if there is a uveitis with cataract, and if cataract is responsible for uveitis, that means leakage of proteins and then uveitis, any difference in management?
Sir, the management has to be take care of the the inflammation, control the glaucoma if it is existing, and do the surgery. If
where lens is the culprit, should we wait for 3 months?
no, not at all.
Sir, in case
Otherwise
there is, sir, in case it is uveitis with cataract, the thing we take care of first is uveitis, and we wait for the inflammation. If it is cataract with uveitis, we will take care of cataract only. The uveitis part will get taken care of simultaneously, except we might need to be more aggressive with steroids, including oral steroids.
Sir, I think one point is that if there is pre-existing uveitis, for example, patient of ankylosing spondylitis develops a cataract, the post-operative need of steroids or immunosuppressants will be there. But if it is a case of cataract causing uveitis, let us say phacoanaphylactic, then the cataract surgery in itself is the treatment of that case.
What will be the role of mydriatics post-operatively?
Thank you.
if you have a posterior capsular defect. That's what. So there is no posterior support. Which type of IOL would?
I think we can have a tuck. We can the haptic can be put in the bag and optic can be there in the cell.
There is no support.
Sir,
not at all.
No bag.
It has to be scleral fixation only,
I
and
think
whatever is
only
best
scleral
in your hand. Yamane, some people will prefer Yamane because it's very far away from the the scleral body. But whatever is best,
Yeah,
but
or a
definitely
glued
nothing to
IOL
do with
also.
iris.
Or a glued IOL.
Or
Of course.
all
that
the
is
same.
Yeah. So we'll have the next speaker, Dr. R.S. Chauhan, sir, and he'll be talking on rare and interesting cases in ophthalmology.
Respected teachers on the dais and dear colleagues of the dais, I am talking about some interesting and rare cases in ophthalmology. This is the first case. It was in 2005 in Oman. The patient had history of injury with wooden stick, but when careful examination was done and X-ray was taken, then it was a metallic phone body, and further counseling revealed that it is a gunshot injury. And this was the gunshot injury which was seen on the X-ray examination, and finally that had to be taken out. So sometimes the patient gives wrong history, and if you do not do proper examination, you probably can leave it. So it is better to always counsel, and in any orbital trauma, X-ray is a must, because that is non-invasive, and sometimes if there is metallic foreign body, then it can be pointed out. This is another case in 2006. This was a 25 years old kabaddi player. So there was history of injury with the knee while playing, and history of LASIK surgery. In 2006, it was like in Gulf country, because they used to go abroad and get surgery done and come back. And on examination, it was avulsion of LASIK flap. So sometimes you see the problem is that in Gulf country, you cannot touch the eye, and if something happens, they will put you behind the jail. So that is why nobody was touching it. So that flap appeared to be clean, but when I washed it and with the gentamicin, it became little opaque. So I was worried what happened. But final cleaning with the normal saline, and it was deposited back, and after 1 week there was interface debris, which was called sand of Sahara. This was one of the interesting cases at that time. So these are the other photograph of that case, because that had to be kept on watch, because there was no cornea specialist at that time in that particular area. So patient refused to go anywhere else. This is another patient. This was a young girl, 18-year-old, and she had injury with the lead pencil. This in the childhood, and this was lying there for the last 12 years. The vision was maintained around 6/9. This foreign body was removed, and there was no inflammation. But the problem was, because after the removal of the foreign body, that healing was delayed, because that lead particles were not removed from that area, and it had to be sutured again. Now this case was also published later on, and what happened? This is another very interesting case. This patient, he was a 12-year-old boy who was swimming in the sea, and when he came out next day morning, he started having orbital cellulitis. He was treated with IV antibiotics and anti-inflammatory, but he was not cured at the peripheral health center for around 10 days. The patient was referred to us. When the X-ray was done and the CT scan was also done to find out what is there inside. To the utter surprise of the radiologist, he called me actually. He told me that, Dr. Singh, listen, there is some foreign body. The value of that Hossenfield value of that is more than the bone, but less than the metal. So neither it is metal nor bone. Then what is this? So this was, the globe was intact at least, and this orbital foreign body whose Hossenfield unit value was more than that of bone, that was 700, and less than the metal. Usually metal is 3000. So this careful history was taken, and the father of that boy told that there is a fish which is called flying fish. It jumps with a speed of 120 miles per hour, and sometime this fish will strike the face, and this beak will enter into the orbit, and it must have entered into the orbit, and probably that is the foreign body. And he actually brought that fish, and that fish was shown to me, and then this foreign body was removed, and this was another very interesting case. This is another interesting case. This was an IPS officer admitted in Ward 11 in PGI Rohtak. Dr. Nagpal was treating that patient, but that patient was not allowing to touch the eye. He was having non-healing corneal ulcer. So he asked me to examine properly and find what is the problem. But he didn't allow me to touch the eye, so I told him, listen, I cannot do anything without touching the eye. Put the paracan, took him to the minority, everted the upper eyelid, and to my utter surprise, behind the upper eyelid there was a ring of the eye drop. Can you see that? This is the ring that between the cap and the bottle. That ring was underneath the upper eyelid, and that was causing irritation to the cornea, and that is why it was not healing. So that was taken out, and after that that patient healed. So these are some of the interesting cases I encountered.
Thank you so much, sir. Very interesting cases, and I wonder what happened to the child with the pellet, because here we are obligated to inform the police. There, what was the, there they would have, killed the person who. So was it informed there? Is it mandatory to inform the police?
There
about
is
the
different
pellet?
department. Medical legal department is different. Everybody is different there. So our job is to do our job. So their job is their job. So
But
they will
if you
take care
find
of
a
it.
pellet, do you have to inform the?
No, that everything has to be informed, because the radiologist will inform that there is a pellet.
Thank you, sir. Thank you so much. And
Sir, one comment I would like to make. Thank you for the, it brings a memory that what can happen in Rohtak doesn't happen in any other part of the world. And practically anything can happen in Rohtak. I've had the chance of having all types of injuries, tractor, combustion chamber injuries, blouse hook injuries. The tire blast injuries. So, Rohtak has its own charm.
See, actually
And
what happens,
thanks.
it is not the Rohtak, because nobody tries to touch those patients. They will refer the patient to
Actually, sir,
RIO.
Rohtak patients do not allow anyone to touch them except Rohtak doctors.
See, that patient was police personnel, IPS officer. So nobody was even, so I was wondering how that ring went inside the eye, inside the upper lid. Yes.
So maybe he thought it was a golden ring and he was trying to smuggle through the custom office.
so we'll move on for the paucity of time. Dr. Manpreet is here. Dr. Manpreet is not there. Dr. Neha, would you be presenting? Okay, fine, please. That was amazing. Yeah. That is the only injury we cannot find in Rohtak.
No, sir. Even fishes can fly in Rohtak.
Good evening, everyone. Myself, Dr. Neha Adlakha, and I will be presenting in place of Dr. Manpreet Kaur. The intimate ties, MGD and dry eyes. This is not working. As per the dues, dry eye is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms with tear film instability and hyperosmolarity. The International Workshop on Meibomian Gland Dysfunction described MGD as a chronic diffuse abnormality of the meibomian gland characterized by terminal duct obstruction along with qualitative or quantitative changes in glandular secretion, which can cause ocular surface irritation and ocular surface disease. Newer advances in management of MGD, non-contact infrared meibography. Meibography is basically a technique to visualize the morphology of meibomian gland. Changes in morphology of meibomian gland associated with MGD can be dropout, shortening, truncation, distortion or dilatation. There are three types of non-contact meibography: slit lamp based, mobile and topography equipped. In addition, interferometry equipped, fundus camera equipped and iPhone connected mobile systems. Tear interferometers like LipiView and DR1 alpha is used for dynamic meibomian imaging, measure lipid layer thickness and image meibomian gland structure. This is the image of meibomian gland dropouts. Oculus keratograph, it has built-in real keratometer and a color camera optimized for external imaging. Additional features include examination of meibomian gland, non-invasive tear film breakup time and tear meniscus height measurement. In vivo confocal scanning laser microscopy, it basically provides high resolution images of meibomian gland architecture, including acinar density, diameters, orifice area, acinar irregularity, reflectivity and fibrosis severity. Various inflammatory biomarkers like cytokines and other mediators, matrix metalloproteinases, human leukocytic antigen DR isotype can be tested by tear sampling. Tear osmolarity, and insufficient tear film or unstable tear film is hyperosmolar. It can be measured by tear osmometers. Newer in situ osmometers are portable and handheld. like Scout Pro and iPen. Therapeutic advances, intraductal meibomian gland probing. Intraductal probing is basically a slit lamp procedure involving the mechanical opening and dilatation of the blocked meibomian gland orifices. It helps by releasing the meibum, opening the blocked ducts, and improving the effectiveness of topical medications. Thermal pulsation therapy in FGD, the altered meibomian composition leads to increased melting point. Heat helps by locally raising the temperature of eyelid, melting the infiltrated meibum. Expression of meibum is an effective treatment method when combined with lid hygiene and hot compresses. Several electronic heating devices are available like LipiFlow, Tear Care. This is LipiFlow, this is iLux. Meibo Thermoflow. It is basically an in-office therapeutic device for treatment of MGD-related dry eye disease, which maximizes meibum liquefaction and secretion, thus improving tear film quality. Intense Pearl Light. It uses non-coherent polychromatic light source with a broad wavelength spectrum and is used for aesthetic or therapeutic purposes in dermatology. This is how IPL is used. Blefex. It is a treatment for blepharitis that can be used in office. This handheld device spins a disposable single-use medical-grade microsponge on its tip to micro-exfoliate the lid margins and lashes so as to remove the debris and biofilm at the lid margin. Intranasal tear neurostimulation. In 2017, an intranasal tear neurostimulator was approved by FDA for treatment of dry eye disease. Pharmacological advances, emulsion eye drop containing lipids in evaporative dry eye disease. Related to MGD, the pathology is thin or abnormal lipid layer in tears, leading to tear film changes. Topical dicoxazole, topical cyclosporin A. It is the only therapy that has been clinically shown to increase production of patients' own natural tears. Basically, it's a highly specific immunomodulator that affects primarily T cells and decrease the inflammation of the meibomian gland and reduce their plumbing and dysfunction. Topical vitamin D3 analog. An association between dry eye syndrome and vitamin D deficiency had been suggested. Vitamin D has immunomodulatory effect. Application of mexaclassitol ointment to the eyelid margin with obstructive MGD for 2 months has shown a significant improvement. Lifitegrast is an immune-inhibiting drug that reduces inflammation by preventing lymphocytes from binding to other cells in the body. Antibiotics with anti-inflammatory activity, tetracyclines and macrolides are 2 groups of antibiotics that play a role in management of dry eye disease caused by MGD. Oral doxycycline or minocycline successfully improves symptoms and signs. Azithromycin, either oral or topical, also produces the same results. Oral supplementation with omega-3 essential fatty acids. Omega-3 essential fatty acid supplement improves some clinical symptoms and signs. It has shown to decrease inflammatory markers. Lifestyle interventions. Dry eye is basically a lifestyle disease. Lifestyle intervention related to physical activity, diet and subjective happiness may mitigate dry eye disease. MGD is a chronically recurring disease. Though patients tend to have temporary relief, symptoms usually reappear after some time without ongoing treatment. Patient education is important. The patient should also understand daily lifestyle modifications which help prevent disease recurrence. Although a common condition, the management of MGD remains challenging. It is not unusual for a treating ophthalmologist to be perplexed by a variety of diagnostic tools and therapeutic options available. Thank you.
Thank you so much, Dr. Neha. And we have so many modalities through which we can address the situation of MGD. Thank you. Due to paucity of time, we'll be having the questions at the end because we still have 4 more talks to go and just 20 minutes left. So Dr. Ajay Sharma would be talking on flax in difficult situations. Dr. Ajay Sharma, please.
Good evening, everyone. I'll be talking on flax. This is a technique. When it came, I think most of the surgeons, they discarded it, and even that saying that, okay, the patient has to be shifted from one table to another and it takes a lot more time rather than decreasing the time. But ultimately, it has become a procedure of choice now, and as all those probably who have this machine, like for me, we are doing most of the surgeries, around 60% are flax nowadays. So this is what Phaco Energy does, and this is what we get in the flax: clear corneal incision, LRIs, capsulotomy, and lens fragmentations. The technology gives us 360-degree 10,000 scans here. I'll just skip this and directly go to different. This is how our docking is being done, and then the femto is being done. And there can be LRIs which can be intrastromal or anterior penetrating also. And so we use this in all the cases, whether it can be normal cases where what it does, it reduces the effective phaco time, because lens softening is done by use of use of the femto, and effective phaco time is reduced up to 70% in most of the cases. So now we do in different scenarios. If we see the grade 3, grade 4 cataracts, where we feel that while we are working normally with a phaco chop, there will be a lot of edema next morning. But here in with the flax, there is negligible edema even in grade 4 cases. We see that on the right hand side, that this is a grade 4, and how nicely there are 4 pieces. The fragmentation has been done, and by just dividing, the already divided thing is, and you can eat on to the lens material. And here, as I said before, the effective phaco time is less, because already the lens is fragmented, and you can see that honeycomb appearance in between. So it is further liquefies the lens, softens the lens, and you can just use less energy, and less phaco time is taken. It can be done in post-RK patients. This is a difficult situation. Post-RK, we all are worried how it will be done. But normally the central part is always clean in the post-RK patients. And this is how the femto looks like. What we are doing is, this is the femto. And you can see these marks out here. So these are the post-RK marks, and these are the marks. And the femto is being done, and once the femto is done, so you can very nicely take out. You have to give the incision just between the 2 RK marks, and try to see that the wound doesn't open, the marks doesn't open, which at time does if the cataract is hard and you're taking a lot of time, and if the distance between the 2 cuts is less. So at that time, then you need to, if that occurs, then you need to suture that wound. This is in the hard cases, the post RK. You can see it's a sort of a grade 4 cataract, and but again we are in between the 2 marks here and here. This is a toric lens was to be put here, and very nicely you can divide it, and you can eat the nucleus. If we continue with our manual incision and manual things, so it will take a lot of time also, and chances of the opening of these the scars are more here. So then this is again very important in cases with the hypermature cataracts. We most of the time see that even after doing each and everything, there can be this type of rupture of the capsule. But here this is an amazing thing. In less than in around 1.2 second, the CCC is there, and most of the cases there is a free floating CCC. Out of, I think, more than 10,000 cases what I have done, there was one case where I found that CCC was not free floating. So this again is a boon, and this is something where we are doing it in a subluxated cataract. And again, it is very easy to dock and see. You can see there, this is the gap between this is the gap. You can see the subluxation here. So but here the OCT takes it very nicely, and you can do the capsulorhexis. And once the capsulorhexis and softening is done, then it is again very easy, because again maneuverability here, you can see how much the subluxation is there. But I am taking this rhexis off. Mild hydrodissection is being done, and at a very slow parameters, not very high bottle height and all that, we take the lens out. So this was a patient of thalassemia, and where again the 35 years old only, and there was surprisingly no vitreous loss here because of the age of the patient, and we so nicely keeping just the tip here, and we are taking out the nucleus, and there is no problem, and it was done very nicely. This is something interesting which I would like to show, and I'll close it after that. Is this is post ICL surgery. So we thought there was a patient where ICL was done and the cataract was to be done here. You can see the cataract here posterior subcapsular one. Now it was the OCT won't take it in one go, so then here you need certain adjustments which can be done. You can adjust the wherever you want it. So like we are adjusting it here, we take these are the adjustment parameters. So you take them up, down, whatever it is, and here we are adjusting the posterior part of the cornea, then the anterior capsule is adjusted, and finally we got it right, and there was the femto was done like this, and you can see very nicely the ICL here. This is placed. This is the ICL above, and this is the lens here. So it can even be done in that. This was one case where we machine didn't take it, we have to adjust. But in second case, this was very nicely taken up by the machine. Look in first go. So the docking is done, and we can just see this again you can see the ICL here, and in one go it was done. And this was the case where after that we just took the lens out and the ICL out first by undocking it out of the pupillary area, and taking this out, and then the normal cataract surgery was done. Now this is possible with the femto. This is an amazing thing which we found, and so though now once it is done, we can just take out now this is a mild hydro, and we take out the lens also and implant the lens. So we can go on and on, but I think time won't permit it. Thank you very much.
Excellent presentation, sir, and the excellent videos that you have shown. And I think now we can do anything with flax in any grade of cataract. Yeah. So next.
Sir, for the next presentation, I'll invite Dr. Professor Sumit Sachdeva. He'll speak on evaluation of the optic nerve head in glaucomas.
Good evening, everyone. So my topic would be on glaucoma and the importance of optic nerve head evaluation. As we all know that we are seeing a number of cases of glaucoma per day. And why is the disc evaluation important? Because optic nerve is a place where over 1 million nerve fibers converge, and they pass the information on to the brain. And the evaluation of the disc gives us little clues which will help us in managing or detecting the glaucoma part at a very early stage. Now there are various modalities through which we can do a glaucoma screening. That is, one is the direct or an indirect ophthalmoscope, which all of us have, fundus photography, and OCT. Fundus, and even if the fundus photography and OCT is not available, we can use a good direct or an indirect ophthalmoscope. Indirect is preferred, or a slit lamp biomicroscopy. Now, optic nerve head evaluation, we do it in 3 parts. One is the disc morphology. We see the disc, we see the size of the disc, the shape of the disc, what is the NRR, what is the CD ratio. We see the area around the disc, the RNFL changes, the parapapillary area, and thirdly, the vascular changes that are occurring. So if we take these 3 into account, we'll be able to judge what kind of a disc is likely to be glaucomatous. This is the arrangement of the nerve fibers. We know that the arcuate fibers are converging on the disc from superior and inferior poles into the poles, and these are the poles where we find the earliest damage of the glaucoma. Now, size of the optic disc correlates directly with the cup. If you have a size less than 1 millimeters, which is a very small disc, you'll likely to have a cup of very small size like 0.2. And if you have a disc of more than 2, then you have a 0.55 or so, which is normal for the range. Now, size determination can be done with the help of a 60 or 78D lens. You put the 60 or 78D lens in front of the eye, you adjust the graticule on the slit lamp and do the reading on the scale, and accordingly categorize with you adjust for the correction factor. For a Vogue 60D lens, you don't need to correct anything, but a 78D you have to multiply by 1.1, for 90, 1.3. So average vertical diameter is 1.8 millimeters, average horizontal is 1.7. Anything above or below that is a small or a large disc. Almost all the discs, it is said that they follow the ISNT rule, where the inferior neuroretinal rim is more than the superior, which is more than nasal and temporal. But we should understand that approximately 30% of the eyes do not follow it. So even if an eye is not following the ISNT rule, please don't jump on and label the patient as glaucomatous. The DDLS came by Dr. Spaeth, and he said that instead of CD ratio, you look at the rim to disc ratio, and a rim to disc ratio is a much more sensitive indicator of a disc damage than the CD ratio. So disc damage likelihood scale was given. This is the normogram which is given, and you see that in a small disc, even a 0.2 disc to rim ratio the person is at risk, while in cases of large disc, even up to 0.1 can be adjusted. So what is a glaucomatous disc? Glaucomatous disc is where the cupping is fundamental. It is a type of optic atrophy where there is a loss of neural tissue. But one thing to remember is that the neuroretinal rim remains pink till the very end, and it is only pale when the optic disc is atrophic. Look at the notching, focal notching. Now three things: focal notching, the sector defect, the Arnefeld defects, and the splinter hemorrhages. They go together most of the times. So and saucerization is one thing that we need to look at, that where the paler does not match with the optic cup. So you see that in the right, we see that we try to mark that the center one is the pale area and this is the cup. But we have to look at the vessels. They are bending way down at the optic rim. So we are missing out on this area, which is also cup. So this is a shallow cupping, which is saucerization, which follows a chronic kind of a glaucoma, which is a slow progressing glaucoma, where we find saucerization. Nerve fiber layer changes, we have to look at the changes in red-free light, because in the normal, we can miss some of the points, some of the areas. And nerve fiber layer defects can be focal or diffuse. Most of the focal defects, they follow the two criteria. The defect should be of the same caliber as that of a vessel or arteriole, and they must extend up to the disc. Other than that, they are called the pseudo defects. So if you look at this picture, if we are looking at it in a normal light, it looks like a normal kind of a picture, but when you see it in a red-free light, you see the superior and inferior wedge defects. The splinter hemorrhages, are also called the Drance hemorrhages. They are microinfarcts and generally are indicative of normal tension glaucoma. And these hemorrhages, when they disappear from the papillary part first and then from the retinal. So if you are finding something on the retina and not on the papilla, that means it's not a fresh hemorrhage, it is receding. So this is how the hemorrhages look. The peripapillary area is very important. You have to look at the alpha and the beta zones. The alpha zone is, the beta zone is abutting the optic disc, and alpha zone is away from that. Beta zone is more important because alpha zone can be seen in even the normal patients also. So an approximate rule would be that a CD ratio of more than 0.7 with a loss of rim to disc margin anywhere outside the temporal sector strongly suggests glaucoma, and this rule does not apply to a very large or a very small disc. So this is how a larger discs will have a larger cup. Myopia is a very important condition. We should differentiate. We have to differentiate. Look at the size of the disc first. So this on the left you have a glaucomatous disc, while on the right there is a non-glaucomatous, because look at the size. You have a larger sized disc has a larger sized cup, while a smaller on the left side you have a small disc with a larger cup. So a larger cup with peripapillary atrophy indicates a glaucomatous disc. So always draw the disc, always make it mandatory, and comment on the size of the disc in your first go, and make out the remarkable points so that you can look at them when the patient comes to you again. And always document any progression, like you see us bearing of the circumlinear vessels in the next visit, when once maybe after 6 months or 1 year you have to rule. So to summarize, look for the 5 R's. One is the scleral ring to identify the limit and the size of the disc, neuroretinal rim for the ISNT rule, Arnefeld for the defects, and region of peripapillary atrophy, retinal and optic disc hemorrhages. If we look at all these things together, we are likely to catch hold of the glaucomatous disc at an early stage. Thank you so much.
Thank you, Sumit, for the excellent presentation, especially focusing on the disc, which all of us know is an important parameter for diagnosing cases of glaucoma or papillitis or atrophy, whatsoever it is. So it is one of the important clinical skills which one must master. In the paucity of OCT or other, say, gadgets, we should be able to diagnose these cases. Thank you.
So now I'll invite Dr. Rajan Gupta, sir, our General Secretary, Haryana Ophthalmic Society, to present his, sir, on this side, like this, on EDOF intraocular lenses.
Good evening, dear friends. Now I would like to talk about the EDOF, the latest in the intraocular lens technology. As you all know, in the earlier needs versus the difference between the current needs. Earlier needs were the food, shelter and clothing, and now we have added the digital gadget, the mobiles and laptops. So the normal, the need of post-cataract surgery, the normal distance vision of the cataract surgery, and what we desire, it's an increased range of vision without compromise the quality of the vision with the intraocular lens implantation. The various type of intraocular lenses is the monofocal lenses only for the distance vision, advanced monofocal, that is with the distant vision plus functional intermediate vision, and EDOF distance vision, intermediate vision and functional near vision, and the trifocus distance vision, intermediate with the near vision. So the evolution of various IOL designs is initially we had the lens with the spherical aberration. They had simple spherical monofocal surfaces. So there was a point image that was formed on the retina. These extended range of focus IOLs, it was introduced in 2016 by J&J company, that is a Technis Symphony IOL, that is a EDOF. So in the EDOF lenses, it's a new type of IOL category with the optics with the extended depth of focus. So design concept is to increase the positive depth of focus to enhance intermediate and near visual performance while having minimal impact on the distance visual acuity. So it's an increase in the aberrations through refractive or diffractive changes to the optic surface. So what are the various advantages to the multifocal optics? There is less glare and halos, the less loss of contrast at distance focus, and the visual performance improvement at the near may be modest. That is the real disadvantage with these advanced monofocal lenses. The single vision lenses, you can see it forms a single focal point, and the multifocal IOLs, it has a two foci. And in the this EDOF lenses, there is extended depth of focus. You can see a zone which is formed. So it's a EDOF with the quality and functional vision with a no compromise. And you can see the aspheric optic creates a continuous power profile to enhance the intermediate vision. It changes continuously from the periphery to the center of the IOL and creates a unique anterior surface that provides improved intermediate vision, provides distance vision compared to aspheric IOL, and delivers dysphotopsia profile similar to spherical monofocal IOL, and reduces the spherical aberration to near zero. So these are various focal points you can see in the monofocal. There's one focus in EDOF IOL. By Symphony it is two foci. In the multifocal, trifocal is the three foci. And you can see the EDOF IOL, there is an extended depth of focus. So the monofocal at least should give unaided 20/20, and it's a monofocal with the versatility, improved intermediate vision with the EDOF lens, improved uncorrected distance vision, and improved blended mono vision. So the EDOF lenses provide sharp vision over a wide range, allows you to see subject clearly at a different distances from far to intermediate, and daily tasks become easier and more comfortable. So this is the basic. We need a lens, human crystalline lens, at what we have at a young age, that should give us the continuous range of vision with a large degree of accommodation. In the EDOF, there is an advanced optical property with zone of differing surface curvature or have a continuous change in power from periphery to center, which results in light being focused in an extended longitudinal plane. It's a new concept of presbyopic correcting IOL. They work by creating a single elongated focal point, and some designs have center element on the optic that elongates the depth of focus within the eye, which provides a better visual acuity at even 60 centimeter range. So these various selection criteria for EDOF will be patient who demands greater freedom from glasses and good functional vision for performing daily tasks, and the low level of visual side effects for more comfort at night with a precise astigmatic correction. That is, you can provide the toric lenses with the EDOF as well. So this is the difference between the various activity between monofocal and the EDOF IOL. There are various options from all of the companies, that is Magnificent, AdTech, Comfort, Lucidis, iHance, Vivity, InFocus, Sifi, Acumax, Luxmart, Raven, AMA. There's all companies are offering the different lenses, and I think the most of the companies are giving us the better intermediate vision, and that can be replacement for a monofocal IOL without any rings and provide better optical quality than monofocals. The pinhole effect based EDOF or spherical aberration based EDOF are another phenomena which allows obtaining greater depth of focus as compared to monofocals, and it can be categorized as a monofocal IOL but offers a smooth and continuous progression to its power from periphery to the center with no demarcation line. So it is a basically a refractive IOL. It's not a presbyopia correcting IOL. The advanced monofocal, which gives uncompromised distance vision with a good intermediate range of vision. So so comparison, basically in comparison multifocal, they does not generate halos. Contrast sensitivity is good. That doesn't require neural adaptation and monoptic suppression as it is required in the multifocal IOLs. For most daily activities, patients can read without correction, guarantee excellent binocular vision, and levels of acceptance is higher than the multifocals or the trifocals. So you should consider patient needs and expectation, but highly criticizing patients who are demanding, I think you should go for a monofocal. When patients have corneal pathology or any other macular pathology, I think the monofocal is the best choice. But we can consider this is advanced monofocal in such cases. So you have to look for the personality type of the patient, visual needs, the profession, and lifestyle and daily activities. So thank you. Thanks a lot for your patient listening.
Thank you, Dr. Rajan, for a comprehensive talk on the EDOFs, and I think we all are moving towards EDOFs and advanced monofocals nowadays. So last talk would be by Dr. Neha, and she would be talking on tear furning in meibomian gland dysfunction. I think we have already exceeded the time. Dr. Neha, I would request you to please be just on precise.
Very good evening, everyone. Myself, Dr. Neha Lakha, Associate Professor, SHKM GMC Mewat, and I will be presenting on tear furning test in meibomian gland dysfunction. In the past, the assessment, diagnosis and management of MGD has been inconsistent due to lack of a clear definition and classification. Thus, TFOS workshop on meibomian gland dysfunction reviewed the causes, pathophysiology, diagnosis and treatment of the condition. This article summarizes the conclusion and recommendation of the TFOS workshop on MGD. As per the Beijing, Japanese and Shipai eye study, the prevalence of MGD appears to be higher in Asian population, around more than 60%, while in India, prevalence may vary between 30.5 and 54.1%. As per the TFOS workshop, MGD is defined as a chronic diffuse abnormality of the meibomian gland, characterized by qualitative or quantitative changes in glandular secretion and terminal duct obstruction, which can cause symptoms of ocular irritation and ocular surface disease. Meibum from the normal meibomian gland get delivered to the marginal reservoir, which gives rise to lipid layer of the tear film. Meibum spreads to form a stable lipid layer within 1 second. In meibomian gland dysfunction, there occurs orifices obstruction by hyperkeratinization of the terminal duct epithelium and increase in meibum lipid viscosity. In non-cicatricial MGD, there occurs plugging of the orifices on the eyelid margin, and on expression, there are cloudy and opaque secretions. This is how, on bimanual expression of in non-obvious MGD, opaque meibum looks like. Tear furning test basically detects quality and stability of tear film. Tear furning is dependent on ratio of sodium and potassium ion to calcium and magnesium ions. Differences in electrolyte concentration may be related to different furning patterns. Tears are collected with a glass capillary tube placed on a glass slide and left to dry at room temperature. After crystallization, samples are observed in white light or by polarized microscopy and classified by Rolando classification. Dry eye patient exhibit less furning than the normal patient. This is the Rolando classification. Type 1 and type 2 are considered as normal, and type 3 and type 4 are as abnormal. In type 1 pattern, there are lots of ferns which are tightly packed together. In type 2, there is abundant ferning but with spaces. In type 3, there are scarce or single ferns, while in type 4, there is absence of ferns. A standardized grading system in MGD allows an organized approach to treatment rather than random grab bag approach. Poor correlation between the clinical signs and symptoms make it difficult for the clinician to apply a scientific basis to clinical management. The problem is compounded by difficulties of evaluating the tear film due to transparency, small volume and complex composition. The presence of a biopolymer is important, but this need not specifically be mucus. MGD is more common in women and its incidence increases with age. Tabara and Okamoto as well as Orlando propose the use of tear ferning pattern to evaluate tear quality. Tear ferning pattern have been investigated in association with overnight variation, post-menopausal women after pterygium excision and contact lens wearers. Practical insights into tear film composition is very important for diagnosis and treatment, but detailed analysis is restricted to expensive laboratory-based system. There is a pressing need for a simple test. The tear film ferning test has the potential to be applied in the clinical setting to investigate the tear film in a simple way. No single test of tear function can give a definitive diagnosis of dry eye. Knowledge of the ferning pattern of various bodily fluid hold great utility in healthcare field. As technologies continue to advance, technology that have previously been confirmed to laboratory will become more clinically accessible. Tear ferning test has certain limitations. Care should be taken not to elicit reflex tearing during collections. Light microscopy is often unavailable in the clinics. Test is affected by extreme condition of temperature and humidity. Thank you.
Excellent talk, Dr. Neha. And I think we'll close the session now. We are already over time. I would request, for a group photograph. I think every one of us can be there on the. Yeah.
आपके लिए बैठा था।